there's, really trying to eliminate some of the waste in the system. We know over the course of time that, not everyone needs the highest level of care, that if you're able to function and perform well with less restrictive settings and the appropriate supports needed, that you can really remove a lot of waste in the system and reinvest it in, new programs.
I think talking about the reimbursement models is the legacy of fee-for-service. And despite the fact that I think everyone wants to move towards a value-based care world, there is this sort of challenge when you're talking about how do we move something from fee-for-service into a capitated rate or a case rate or a PEMPM, and how can both sides be confident that this is an investment worth making. Hello, and welcome to the Self-Disclosed Podcast. I'm your host, Patrick Gilligan, and today I had the pleasure of speaking with Deb Adler, who is the CEO of Navigator Healthcare. Deb has a long career with over 25 years of experience as an executive in health plans and has now taken that experience into her own startup, Navigator, to help support those navigating the complex landscape of substance use disorder. This conversation was super interesting. We got to talk about her experience working for health plans, how innovation happens at health plans, and what are some of the challenges and incentives that both drive and hinder innovation in health plans. And then we talk a little bit more broadly about the behavioral health space today and what are some challenges facing it. So it's a really fun podcast. I hope you enjoy. As always, this podcast is sponsored by Somethings. If you want to check out what we're up to in adolescent mental health, you can visit our website at somethings.com, or you can check me out on LinkedIn and find some of my posts there. Without further ado, here is the podcast. Awesome. Deb, thanks for joining us today. Really appreciate you coming on.
Yeah, thanks, Patrick. Happy to chat with you.
So it's been really awesome working with you over the last few months, and I've gotten to learn a little bit more about what you're doing at Navigator. But maybe we can start today by just having you share a little bit more about how you got into the healthcare industry and sort of like what was your first start and first moments?
Oh, yeah, happy to do that. I've been in the industry a long time. So I actually got into healthcare through the statistics store. I have a master's degree that emphasized statistics, educational psychology, and evaluation. So my first healthcare job was as a program evaluator for a New York State operated psychiatric hospital. So I was able to learn very early about various behavioral health programs, the full continuum from outpatient to partial to forensics to inpatient. I got to see it all from the inside. And that really propelled me to later learn more about managed care, because that was the hot thing at the time. So I came in through a statistics store and then kind of stayed in the behavioral health space ever since post my master's degree, working at two large health plan payers. So I worked inside payers for about 25 years and then have been working outside of the payer, working very closely with payers for the last 6 years.
Love that. Did you have an interest in behavioral health before you worked at the psychiatric hospital, or was that your first experience with behavioral health?
It really was my first experience, other than psych course in high school, right? I found that always fascinating, but no, it really was. And so I got to interact with patients, right, in that setting, with clinicians, with administrators. My role was very heavily focused on quality management and how to, improve processes and outcomes at that center, including things like accreditation, making sure the programs were accredited. So it was my first foray, but just loved it and stayed in it ever since.
Talk to me about the early days of managed care that you saw and all the excitement around that when you were first coming in, and maybe the journey of how you've seen that change over the course of the 25 years that you were working within the health plans and now today.
Yeah, I think in the early days of managed care, there's certainly, and there still is, a huge focus on achieving the best quality outcomes and healthcare cost savings, right? And there's, really trying to eliminate some of the waste in the system. We know over the course of time that, not everyone needs the highest level of care, that if you're able to function and perform well with less restrictive settings and the appropriate supports needed, whether that's individuals with lived experience or continued outpatient clinical therapy, that you can really remove a lot of waste in the system and reinvest it in, new programs. So I would say in the early days of managed care, my first effort was in a Medicaid program in Colorado. It was pretty exciting because we had strong partnerships with our providers. We co-owned the program with the provider community, which was a unique model. And when we had achieved savings and removed waste out of the system, we reinvested that into programs that we felt were needed, like drop-in centers for members that they could go to and have resources and supports. Well, we were able to reinvest. I think we went from like no drop-in centers to like 50 around the state. I mean, so it was really kind of exciting to see that reinvestment of funds. That was a Medicaid program. So come full circle 25 years later, there still is some focus on reinvestment. Today, compared to then, there's a cap. Most states put a cap on how much profit a managed care company can earn, whether you're co-owned with providers or not. And there usually is. If you earn more, you still need to reinvest those dollars. So I think that still exists, but I don't know if that the dollars are as significant as they once were. I think we've come a long way and have a long way to go in reimbursement models. Back then, everything was fee for service. No really unique, not a lot of unique programs, some capitation payments in some cases, but very little in the behavioral health space that was outside of fee for service. And that's still somewhat true today, but there has been some innovation and changes that promote different payment models with the goal of, again, improving the member's outcome, quality, and saving costs.
Going through all of that, I mean, I think the premise of managed care is great, right? You give someone an incentive to reduce costs and drive better outcomes. I'm curious to hear if you think it's been effective, over the course of the last 20, 25, 30 years, given the context that healthcare spend continues to increase in the US, there are lots of populations that continue to be underserved. Like, how effective do you think managed care has been? And maybe where are some areas that you feel like there are still room for improvement?
Yeah, I think, managed care organizations are very big and complex. And so I do think innovation and change is very slow. It moves at sometimes what feels like a glacial speed. So the amount of change, things like, every conference you go to, what's all the chatter about value-based contracting, alternative payment models. We haven't moved very far, at least in the behavioral health space in that arena. There are reasons for it, right? There are things that are barriers and challenges. And I do see Medicaid programs usually being more innovative. They have a concentration of membership in a single state, right? In a single regional area. So you can do more things with more people, with more volume. And it is more challenging in the commercial world where membership is very dispersed. And we haven't come very far in, I think, consensus around, well, what are we supposed to measure, right? What are the right measures? Things like member reported outcomes certainly have continue to be important, and they were even important back in the 80s. So maybe they weren't the GAD and the PHQ, but they were important then, right? That hearing directly from the member about their experience and their empowering the member to let us know how you feel. Are you better as a result of treatment? I think is still, the good news is that I think that's still important versus, the clinician certainly brings a lot to the table, but you want to hear it from the horse's mouth, so to speak, from the member themselves. Are you better? So I think that's still valued, but we're really challenged in the behavioral health space because of the array of diagnoses, and many of these instruments are very diagnostic specific, right? They focus on anxiety and depression, there's such an array of measures to collect related to the diagnosis that it is hard to really get a good sense of improvement for a population, right? The metrics are still a challenge.
I've noticed that as a misconception across people who are not very deep into the behavioral health space, which is sort of this lump together of all mental health diagnoses and disorders. And I think maybe the thing that is not clear to people who don't spend their lives in is how broad the spectrum of issues that individuals can face and the variety of treatments, interventions, like you said, measurement tools that are required over the course of a population, which I think poses unique challenges when you compare it to something like cardiology or a field that maybe in the physical health side is much more developed. I've heard a lot about the barriers and challenges to alternative payment models, value-based care models, and just how difficult it's been to actually deploy these to the point where the providers and the health plans are both succeeding. What have been some of the things that you've seen that have proved challenging with providers and payers trying to implement real value-based care arrangements?
One of the barriers, of course, is volume, right? You have to have a sizable population to really make these programs work. And that a smaller provider organization, that's going to be a real challenge. You may be very excited to do, pay for performance initiative and be rewarded for value. But if you're critical mass of members, it just, the payers aren't going to be that interested, right? They need to, it's a lot of level of effort. And one of the challenges, we won't talk only about challenges, but one of the other challenges is the payment systems, right? The claim systems that the payers are using. Not all are configured in a way that make it an automated approach to managing things that, like bundled payment or case rates. So not all have their claim systems configured to allow this to be easily deployed, right? And no one really wants to set up a manual process to measure and manage these kinds of things. But, I do think many of the payers have gotten creative. They have made changes to their system. So they're certainly working to make those changes, but those are some of the barriers.
Something else that comes up for me too, I think talking about the reimbursement models, is the legacy of fee-for-service. And despite the fact that I think everyone wants to move towards a value-based care world, there is this sort of challenge when you're talking about how do we move something from fee-for-service into a capitated rate or a case rate or a PEMPM, and how can both sides be confident that this is an investment worth making? And I think we've sort of, in my experience from talking to people, it's sort of been like, hey, this is great, let's shoot for this, but we need to start in the world where we are comfortable, which is fee-for-service, which I think can be challenging for specialty providers who are trying to provide new care delivery models that don't fit into a fee-for-service paradigm at all.
Right.
What have you seen there in terms of like plans' openness to totally new, totally novel, non-fee-for-service service delivery models, products?
There usually is not a lot of receptivity out of the gate, right? They really want to test and learn. Payers typically want to test and learn and start in a fee-for-service model, learn a little bit more about utilization and performance before they work their way up to other payment models, right? So you're not going to jump from fee-for-service to capitation. Typically, they're going to do some things in between, like case rates or pay for performance before you leap up to capitated rates. I think what I've seen typically is some willingness to offer an enhanced fee-for-service, knowing that, like you said, unique programs may not fit into that traditional mold. There may be services that are being provided that are not claimable services, right? There's just not a code for that service. Or a great example in the commercial space, peer-directed services usually are not a covered benefit. That doesn't mean they don't add value, right? Or other, CBT or other tools might add a lot of value and result in better outcomes and cost savings. So I have seen payers willing to pay a higher fee-for-service rate to test out that theory, right? Let's deploy that unique non-billable program. We want to test it out, but then we'll pay a little more for the the traditional services that can be noted on a claim. So that's usually the route I've seen if they aren't quite willing to take that risk out of the gate, because it's just the payer.
Deb, you've seen, I'm sure, a lot in your time at health plans, and I assume you could have probably completed your career there and been very happy and satisfied. Tell me about the problem that you saw that made you want to leave and actually go start Navigator and do your own thing.
Yeah, I spent my last 5 years at the payers, putting a lot of time and energy into the substance use space. We're seeing rising spend trend year over year in that category, led the network team. And so we had developed a very robust, effective medication assisted treatment network, that being the evidence base for substance use disorder, only to see that no one was using these great services, right? So you can build anything, you can build a network that offers good access, but without engagement of the member, you're not going to see, improvement or better outcomes. So when I left my payer job and had the opportunity to do a startup very late in life, I might add, I thought this is an area with my co-founder that we could really make a difference in. That, how can we educate members? How can we offer the right type of health literacy program that really brings people to right care at the right time and leverages these resources that do exist, most individuals are unaware of. So it was a really great opportunity to try to, again, test and learn whether this model can work. And I have found, you can move faster, develop, I think, innovation a little more quickly outside of the payer. I'm certainly leveraging a lot of my knowledge from inside the payer, but being able to build a network and offer a unique service has been, a very important mission for me, but also, a great way to take those learnings to the market.
What were some of the learnings or insights that you had from your time in the payer space that you felt were really valuable when starting Navigator and getting things off the ground?
Yeah, I mean, I know, kind of the various functional departments within a payer. So that always helps, right, to kind of know who are the decision makers and how do they think, right? I still say I think like a payer because I was in that field for so long. And I knew whatever I put together had to solve a real pain point. It had to be something that the payer knew that, they needed it to be solved. And I know that in the substance use arena, employers continue to see, a lot of individuals not getting the help they need or as quickly as they need it. We know that 66% of people with SUD, with substance use disorder, are in the workforce, right? And it has a significant impact, if untreated, on things like absenteeism, presenteeism, turnover, as well as medical spend. So I really tried to pick something that I knew was a pain point for the payer and could solve a real problem, both from a cost and quality standpoint.
Tell me about the mindset of a payer. You say you wear the mindset of a payer. What does that mean?
Well, I know how busy and distracting it is to be inside a payer. So I know if you're looking from the outside in, it's like, boy, why aren't they moving faster? Why aren't they innovating more quickly? And I think there are several reasons for that. One is, the people that are innovating inside of the payer are often the people that are more willing to take a risk, right? And say, I'm willing to try that out. And if you take a risk, sometimes it works and sometimes it doesn't. So I think that would be one area. Yeah, I think you have to be, passionate about the payer. The payer has to be passionate about the topic that you're bringing to them, right? And certainly behavioral health is a very important topic right now. For me, substance use is, there are fewer entrants in this space. There's many providers of substance use disorder, but not really any organizations that navigate people. So I knew I was bringing something a little new to the table, but the psychology of the payer is if you're bringing something really new and different, accepting that and moving forward with that is taking more of a risk, right? And sometimes it's easier in a big organization to just kind of lay low and not take a risk, right? Because if you take a risk and fail, there could be consequences for that.
What are the incentives that exist within a health plan that disincentivize people taking risks?
Inside the health plan, there are a lot of requirements that just have to get. I wouldn't say it's not always wanting to take a risk. There are also a lot of distractions, and when you're wanting to find the dollars for new innovations, what always gets the dollars first are things that are regulatory, right? And every year there are a lot of regulatory changes in a health plan. There are new codes that come out, there are new CMS requirements. So, right out of the gate, off the top, all the regulatory issues just have to be addressed, right? That's like table stakes.
Yeah.
So, then there's fewer dollars left for innovations. And so you have to be really selective around which of these innovations is going to solve my most important pain point right now. And then how confident am I in this new program that it will be effective? So those are all things I think that weigh into the decision-making process of where a payer can push new efforts, because they might seem to have a lot of deep pockets at the payer. There are a lot of expenses around regulatory requirements that just kind of overshadow a lot of the other initiatives. I used to call
Sure.
the capital committee the food fight committee because to try to get something innovative that required capital dollars was very difficult, again, because most of the dollars are earmarked to making sure the regulatory requirements are met.
Yeah, I think that makes sense. If you were going to be recruited at, pick whichever health plan you'd like, as the chief innovation officer, and your only job was to sort of set up the org or try to change the culture, change the internal way that things worked to try to maximize innovation, maximize driving the most benefit to members, what are some things that you might do, or what are some things that you might want to try to change within the org itself?
Yeah, I think one thing that would be important is to streamline the decision-making process. One thing that's challenging, I think, for a lot of new startup providers is, getting buy-in with the right people so that the effort can move forward, right? And sometimes it's just not even clear who's the final decision maker. So I think one would be having a really clear vetting and decision making process. And I think the other would be, which I've seen some payers do, is to really earmark some funds for innovation, because it may not seem like it's costly to bring in a provider and innovate, but there are time and attention to details that have to take place, whether that's, a unique claim setup or unique integration with the clinical team to make sure this new program actually gets utilized, right? Because sometimes you can sign a contract, doesn't mean that you're going to suddenly see a windfall of members using that new program. So you have to be thinking ahead about how am I going to acquire members? And that's something that isn't the payer's strength necessarily, right? So that making sure that if I were heading up innovation, I'd want to make sure that we not only are, picking programs that are going to be really effective around our most acute pain points. I'm going to also want to make sure that the program is integrated and individuals who need to know or need to be integrated with that program are aware. And that's hard to do, right? Because again, we're talking really big payers are big machines, lots of people, lots of departments. And so making sure the right, I always call it the who else needs to know rule, that the right people need to know how to make this program effective, and that the reporting is in place, right? The reporting and metrics are in place to really evaluate the findings at the end of the day.
I think that's a really interesting idea. It makes me think of, and I'm sad that I can't remember his name, but in the heydays of HP, when they were the hot company, it was a very professional company. People would wear suits. Yeah, innovation wasn't really encouraged broadly across the organization. However, they had special people who were designated as like their job is to try new projects, to break stuff, to move very quickly. And there was this one guy who would show up in like a cowboy hat and full cowboy boots and just look totally different from everyone else. And his job was to actually run innovations, run experiments. And I think to your point, the operation of a health plan is so complex and there's so many things that have to get done. It probably makes sense to set up like a full different process team that operates by different rules, right? And they have a full different process. They have specific allocation funding that they can decide based on the clarity of the priorities, and to just let them sort of like run the pilots, run the things, do the experiments, probably also enable them to be better at marketing than the overall plan, like give them resources to do that as well. Because I totally agree with you. Sometimes getting a contract doesn't really mean as much as we've got a contract and we're integrated, we're generating referrals. And it almost feels like sometimes the innovations are half done at health plans where they have a product that looks shiny off the shelf. They get a contract, but then it doesn't work. And people are like, oh, well, the product must have been bad. But in reality, the implementation was not effective. The process wasn't smooth. So I wonder if like the team set aside could be much more focused on the full cycle of the test of the piloting, as opposed to kind of where it stands like half in the plan, half out right now. I don't know if that resonates.
No, it does, right. To really have I know we try to work with our plans around a detailed implementation plan, but not making it too burdensome, right? Because then, who wants to work with an organization where you've got to do a heavy lift, right? You don't want to do too much of a lift. It has to be a balance of how much lift is necessary to really make this program work or to test out, if it is effective or not. And it's, again, you're talking about many departments, the marketing department, and sometimes it can feel a little siloed within the payer, right? Because, when you're in a company of 100,000 people, just knowing what door to knock on, if you're leading innovations, you've got to, really know the right people to tap and who are the influencers that you need to work with. I will say one of the payers I worked for, they were large. They did try to do a lot of commingling of, I'll say, leaders within the organization through various programs so that there was better understanding of what door to hit, what door to knock on. Because I know whenever I worked for a large payer, I'm like, I know someone here does this job. I just got to figure out who it is, right? Who does this job to when it's such a large organization.
Yeah, it's a really great point. I mean, if there's 5,000 employees, which for most plants probably not even as big as they are.
Number. Yeah, that's a small.
Yeah, who do you call? That is very true. Now we've talked a little bit about the advice or how if you were running a health plan, what you would do to try to bring new innovations. From the provider side, like what are some of the things that new providers should know if their goal is to try to make it easy to have plans say yes to them for new things? Like what are some of the advice that you give to new providers who are trying to bring new innovations to plans?
Well, it does go back to, are you solving what's really a pain point today, right? Because, in behavioral health, I think I saw some number of, I don't know, 1,000 new entrants. It may have been even bigger than that. There's just so many companies, right, in this space as startups, and they've just multiplied since, let's say the COVID years, right? They just really multiplied. So I think solving a real pain point is important. It is interacting with the decision makers, trying to form a relationship with the key decision makers, because what I have seen over the years is that relationships do matter, particularly in the payer space. And so you really have to make sure you've done your homework, I would say, for those initial interactions. It's so hard, right, to get 30 minutes with the chief medical officer or the chief network officer. You want to make sure that your presentation resonates with the problems they're facing today, and illustrates you've thought through, how this can be, best deployed and supportive for that payer. Just think about it. Even when I was there, and that's now 6 years ago, you would listen to so many pitches, right? And sometimes the pitch, it was very clear that there wasn't a deep understanding of some of the real basics, right? Like, you've got to be licensed to deliver certain services. You have to, meet the credentialing requirements. So not that you have to know everything, but I think just that general knowledge set of what the payer's pain point is and what are some of the, I just call them baseline expectations.
I think it's a good point, and I would encourage anyone to show up prepared to any sort of pitch. I guess to dive a little bit deeper there, though, every plan is different, and some plans have the basic problems that I think are obvious in behavioral health: access, specialty providers, but some plans have much more specific problems, or they've really excelled across an access problem, but they're really struggling across some sort of more niche problem. Where do you go when you're trying to understand the problems that a plan is solving? Do you go look at what the CEOs and the COOs are talking about? Are you looking at the press releases? Is there filings that you're looking at? Like, where are you going to actually educate yourself?
That's a good point. I think in the Medicaid space, you have the added advantage of reviewing the RFPs, the request for proposals that the state put together, and historical responses from the payer, right? So you'll know, that'll tell you what the payer is being asked about, right? Or what the state Medicaid program wants the plan to measure. Because I think back to Kansas Medicaid, yeah, the state, at least at the time, was willing to pay additional funds to the payer if certain metrics were hit. So that right away, immediately, well, those 10 metrics, if I can help the payer achieve those, I'm going to be added value, right, to the payer. So Medicaid can be, in some ways, a little easier to figure out what's causing them heartburn or what do they have to deliver to the state, because the RFP may, explain that. So that would be one thing. In the commercial place, I think its space is a little harder, is having those relationships, going to the conferences where the payers are to hear what they're saying, or their pain points, although often I think they're talking about their successes, right? So you might have to ask, if you're in front of a big audience, you're going to talk about your, what you're doing great at the payer. So you may have to ask, what is keeping you up at night? What are the challenges you're facing? I think you can look at some things out in the public domain too, right? SAMHSA publishes studies. That's how, come I know what some of the pain points are around substance use. It's not just the payer's pain point, it's members' pain points as well, right? Or employer pain points. I think the brokers put together sometimes nice summaries for the commercial space, like the Willis Towers Watsons, the Aon Hewitts. They publish, what are some of the top 10 concerns, right? Like cancer.
Yeah.
Is high on the list for employers in terms of cost and quality. So I think, and because we know people during the height of COVID, we're not going to some of their routine visits as much, right? So we're seeing an increase in certain medical conditions as a result, and those medical conditions have comorbid behavioral health needs as well. So I think those are some of the things in the public domain. But again, the more you can establish a relationship with key people inside the payer to hear from them directly, even better, right? Like you can just ask them, right? If I was talking to the head of networks for payer, you might ask, well, where are you seeing, your big cost drivers, or where are your access challenges most acute? I'm hearing a lot these days around the SMI population, right? The seriously mentally ill is an area, teens, youth, always a challenge around access. I remember one of the payers, when you ask them where do they need help with teens, they're like everywhere, which maybe isn't very specific, but I do think you do have to ask, and as part of the asking, you're starting to develop that relationship as well.
Yeah, I think it's totally true. I might also add state regulators, go to them. And like you said at the beginning, the way that they're putting pressure on plans in the RFPs is ultimately what's going to drive change throughout the system, and they're going to know ahead of time what their priorities are going to be going forward. We've also, though state regulators can be tight-lipped around which plans are failing, they'll give you a sense of like what are the problems that they're facing in the state, and those are pretty broadly applicable across the plans. So I think that's maybe
That's a
another
good
place
point.
to go.
Good point.
What have been some of like the most unexpected parts of your experience starting Navigator, and where did you feel like you maybe thought you were prepared, but totally were more hard or more challenging than you expected?
Oh, wow. Let me think here. I think I even though I have kind of the inside scoop of how it works inside a health plan, I think I didn't expect, and I knew the sales cycle would be very long, right? Because I'm offering something unique. It's not a standard fee for service contract delivering care. We're a navigator. I may have underestimated how long it would take for the payer to see that as a gap that they couldn't fill themselves, right? Because I think everyone, I don't know, there's kind of a pride in being able to fix your own problems, right? So, like I said, you got to fix
Yeah.
a pain point, and that is what I'm trying to do. But I also didn't expect, well, I think we'll just fix it ourselves. Yeah, you're right. This is a pain point, but we want to fix it ourselves, and then typically not seeing that fix happen right away, right? Because they have distractions, all the things I said earlier, right? Regulatory requirements, lack of funding on innovation. So I think I knew it'd be slow to market because of, the size and the number of decision makers that have to buy in. But I may still have underestimated that, people at the end of the day are like, I'll just get a hammer and fix it myself. and, because there's that pride and ownership in doing it on your own. So I think that was a surprise to me. I just thought there'd be more receptivity of, yeah, let's fix this now, because there are employers banging their fist on the table saying, hey, what are you doing about this problem? We have a lot of employees who aren't getting access to evidence-based substance use disorder treatment. Our program offers fast access. We, get someone connected within same day or next day. So we're able to offer that speed to access as well as show significant quality outcomes and cost savings. And so, yeah, I think the surprise was, yeah, let's just turn this on faster, because the time it will take us to build this on the inside, the problem's just getting worse. So I think that was one area I underestimated.
Yeah, I think with everything there is education that you have to do around the problem, which I think the important problems people know about, but they might not know the ins and outs of how challenging it is. And then you have to educate them on your solution and why it's better, and demonstrate that it is actually better and that they couldn't build it in internally. And I do think that there is an instinct of like, oh, well, this is important for us. Let's just build it in house, which, to be fair, sometimes they're probably right. Sometimes it does make sense internal. Sometimes the capabilities are just too hard. And I think like we've heard different views from different plans around like where they feel like their core capability is. Some plans do feel like part of their core capability is developing new solutions for their members. Some are like, that's totally outside of our wheelhouse. We just pick the right things for our members. So I totally hear that.
Yeah, it's that buy or build conundrum, right? And so payers are all different in that area too, right? Some, like you said, are like, yeah, I'm just gonna buy it and or not build it myself, because I think what I've seen is to build these kind of unique programs that require proprietary technology to really scale and accelerate is something that would take most payers with their regulatory distractions a lot of time to do. So it could really, to me, speed up, their ability to go to market with something that's unique and helpful for their customers. But I think there is, in some cases, just a general inclination to, build it. If I knew then what I know now, I would have highlighted more maybe what it takes to build this type of technology, that, it is a multi-year process. Sir, could you do it with time and money? The payer can probably do anything, right? They could do anything. But where do you want to spend your time building things, or where is it just as easy to pull something off the shelf that's ready to go 90 days and can be integrated, with relatively low lift. But I think that would be something for any startup to think about, because they will be faced with that buy or build, or the competitor challenge too, right? There are many more organizations out there raising their hands saying, I've got something new and different in behavioral health.
Yeah, we've had the same question, which is like, we've had people point blank ask us, who are your competitors? We're going to go talk to them to see which one we prefer, which I think is fair and part of a competitive bidding process.
Mm-hmm.
What have been the areas that you felt like you had to learn more or grow when you set off to start Navigator? Where were some areas where you felt like you needed to learn more about?
I did have had at least the advantage of working in one other startup. So I had a pretty good sense of I'll just say the hustle required and the wearing many hats, right? One thing I had to learn is I brought in a lot of individuals who came from big payer companies, right? Because there was the talent pool I knew, right? So I brought in people who knew the ins and outs of payers in a similar way that I did, and probably underestimated their experience of working in a smaller organization and having to wear, 2, 3, 4, 5 hats, right? Because startup mentality is different than a corporate mentality. So I did have to learn that, to really help individuals understand that, our budget constraints are different than a large company. Our speed to completing tasks has to be at a much, much faster pace. And the team has really stepped up, but I think that was one key learning. And I think I mentioned it before. Another key learning is you don't get a lot of shots in front of the payer. So sometimes it's better to wait, I think, till you're a little further along in your maturity as an organization, because you'll have a much better story to tell, right? Once findings and data under our belt from a variety of payers, and we can say, we can hit this NPS score, we can achieve this return on investment. That helps propel movement so much more quickly than in the early days when we didn't have a 50 state footprint. We had 25 states. To have some of those things that we know that resonate with the payer, which are, show us your outcomes, show us the footprint. Are you going to be able to be turnkey for us in any market, is obviously more appealing than a handful of markets. So I do think I also learned that, sometimes it might be better to wait if you can tolerate it, wait so that the story is more fully developed and the outcomes are there to help propel the program along.
Yeah, I think hearing that advice is always hard, because I think it's easy to want to just push and do everything, get everything in. And I think there's lots of truth to that, of like, if you go talk to the right person at the wrong time, it's the wrong person.
Mm-hmm.
And I think one of the things that we got advice on early was like, find the people who would even consider using a solution that is not nationwide. Like, don't start with the nationwide plans if that's not even on your roadmap in the next few years. And so I think being targeted about who you do talk to is really great advice. And then I think, to your point earlier, getting in front of the national people or the people who have much broader reach, letting them know what you're doing, but maybe not trying to make that a sales conversation, or not trying to push them towards a decision early, I think can help build the relationship and sort of get on their radar, but not burn the bridge. And I also think on the flip side too, if you're doing something really valuable and you're continuing to build momentum around it, probably no bridge is ever burned. I mean, people swap in and out of plans often. There's always new people to get excited,
That's true. I was going to say there is turnover, right? So that, and you have to pay attention to that too, right? If you have a contract with a payer and you have a strong advocate, you want to make sure it's not one strong advocate, right? That you have multiple advocates because there is a lot of turnover. And I think that's a good point. We went out with a national footprint out of the gate, which would be probably uncommon. So to your point, yeah, targeting your audience in a smaller way, like a single state out of the gate can, be a little easier, right? Then you're not having to wait, till everything is just full. I wouldn't suggest someone would just wait till everything's just fully
Sure.
baked and delivered.
Why was the decision made to go nationwide? Was it something structural about the product that you wanted to offer?
Yeah, we wanted to be able to help individuals with substance use disorder, any market. And because we were targeting large commercial plans, we knew that the solution really needed to be national, right? There are providers that have, footprints in a variety of states, but that's one of the real values, is to be able to offer something that can, support anyone, anywhere, in any state, both through a virtual and an in-person option. So it was a decision out of the gate. And I think, part of it is I have more relationships with the national plans at the time. And so knowing their pain points, right, pushed me more in that direction. But I think it's certainly not necessary. Depends on what you're doing. And you see a lot more companies in specialty arenas right now, right? Just focused on PTSD, just focused on eating disorder. I mean, that wasn't the case 5 years ago. It was more of a generalist picture. And I have seen the payers very interested in those specialties because I think they feel they have a lot of supports for individuals with low acuity, mild behavioral health, anxiety and depression, anxiety needs, but individuals that are intermediate and higher acuity has always been a gap. And I think that's a big concern payers have.
Yeah. I get the sense too that there's a natural widening of breadth of services and then a fatigue of having 40 specialty services and then a consolidation that happens. And then people are saying, oh, that consolidation isn't effective. And so I imagine there's actually a very natural and organic expansion and contraction that happens over the course of time with these plans that is just, sort of part of how it works.
Yeah, absolutely. Yeah, that is true.
So Deb, I always end these interviews with one question, which is, if you could snap your fingers and change anything about the landscape of mental health, what would that be?
Well, it's still, I still think it's a very complex system for individuals that have, need help to navigate. There's, I don't know about you, maybe because I'm the healthcare person in the family, right? Who all, everyone calls me if they have a healthcare question. And I think, if I could snap my fingers, we would probably do more around health literacy for individuals, right? And what's available, what are different treatment options. I mean, it's not something think of financial literacy, right? Everyone has to learn how to handle a checking account or something to that effect. What are we doing to help people understand the complexity of healthcare? And then you could take that down a notch to mental health, behavioral health, because it's so complex to navigate the system. And I don't think it's gotten much easier for people to know how to navigate. So I think if we could, I would love to see the payers and PSAs, public service announcements, that really help educate people on mental health and options and treatment programs and things that are effective and not effective. I mean, I'm sure there's things out there, but is it reaching the masses, right? And is it reaching individuals kind of throughout the course of their life? It's kind of interesting, though. I have grandchildren, and I see some of the movies that newer movies that highlight feelings, and so there is some movement afoot, I think, in that arena. But I just think it's just so complex. We got to do a better job of helping people know how to access care, how to know what's good care from bad care. And that's a role the payer could play a bigger part in.
Yeah. Well, you're doing the important work with Navigator for substance use. So I appreciate that and everything you do. And thanks for making time. I really enjoyed the conversation.
Me too, Patrick. I did too. Thank you.